When we think about fixing something that's gotten kind of stretched out over time, like the elastic waistband of your favorite pair of sweatpants, the logic is pretty straightforward,
Does.
right?
Absolutely. Just shrink it down.
Yeah, exactly. You just, heat it up, toss it in the dryer, and it tightens right back up. It's a very satisfying mechanical fix.
Mm.
But when you step into the world of pelvic floor recovery, treating the human body like a pair of sweatpants and a hot dryer is not just wrong. It's actually a biological trap.
A massive trap, yeah.
Yeah.
Because you expect this simple tightening, and the body delivers the exact opposite.
Right. So I'm your host, and I'm here with our resident expert to look into exactly why that is. Welcome to our deep dive.
Hi, everyone. It's great to be here.
Okay, let's unpack this, because today we're taking you on a deep dive into the realities of pelvic floor recovery. And we are looking way beyond the marketing claims of quick fix vaginal rejuvenation, right?
Right. We really need to look at the true biology.
Exactly. Our mission today is to answer one really complex question from our sources. Can scar tissue after a perineal tear actually make the process of vaginal tightening more complicated?
The short answer is unequivocally yes.
Yeah.
I mean, the longer answer requires us to really look at how scar tissue just completely alters the anatomical landscape.
It changes everything.
Yeah, it literally redefines what it actually means to feel loose or tight in the first place.
Wow. So to understand why tightening a scarred pelvic floor is essentially a minefield,
Yeah.
we first have to look at the physical reality of the tear itself.
Mm-hmm.
And, we know the statistics from the clinical guidelines. Up to, 85% of women having their first vaginal delivery experience some form of perineal tear?
85%. That ranges from, first-degree skin tears all the way through the sphincter muscles,
Yeah.
or they receive an episiotomy.
Right, but the real issue isn't really the tear itself, is it? It's the patch job, the scar.
Exactly.
Like, if healthy vaginal mucosa is this high-quality rubber band, is scar tissue basically like patching it with heavy-duty duct tape? I mean, it holds things together, but it completely ruins the stretch.
That is a perfect analogy. And what's fascinating here is the cellular reason behind that duct tape effect.
Oh, really? What's going on at the cellular level?
Well, when the perineum tears, the body just rushes to patch the area to prevent infection. It's an emergency response.
Oh.
But the new scar fibers that form actually receive significantly less oxygen than normal, healthy tissue.
Wait, less oxygen? Why?
Because they're lacking the complex vascular network of the native tissue. And that lower oxygenation creates an entirely different structural matrix.
Oh, wow.
So the resulting fibers are weaker, they're stiffer, and they have a severely restricted range of movement.
So you're basically permanently altering the biomechanics of that whole area.
Exactly.
Right.
Even with standard pelvic reconstructive procedures, you might only restore about 50% of the preoperative tissue strength.
Only 50%. That's a massive functional deficit.
It is. And, that assumes the healing process actually goes perfectly.
Which it often doesn't.
Right. It can get complicated.
Yeah, it frequently derails into a state called granulation tissue.
Granulation tissue. What exactly is that?
It's basically where the body sort of overheals, right? It triggers this really aggressive inflammatory response. So instead of laying down a smooth, flat scar, the body produces this excess, bright red, highly fibrotic tissue.
Oh, that sounds painful.
It's very raw. It has a raw sensation and bleeds easily, especially during intercourse or a pelvic exam.
Which, makes sense mechanically if the tissue is caught in this perpetual state of active wound healing. But why does that happen? What triggers it?
Usually a localized disruption is to blame. So, for example, during the early postpartum phase, especially if a mother is nursing, her systemic estrogen levels just plummet.
Ah, right, the estrogen drop. Yeah, and estrogen is critical for maintaining tissue elasticity and moisture. When it drops, those perineal tissues become dry and frail. The normal wound healing cascade slows down, and the body compensates with this hyperinflammatory granulation response.
So it's like a localized crisis.
Exactly. Or it could even be triggered by just a single undissolved stitch.
Wait, really? Just one stitch?
Yeah. Even though dissolvable sutures are the standard of care, sometimes a microscopic piece just refuses to break down. It sits there, embedded in the tissue, acting as a foreign body.
So it's constantly irritating the wound bed.
Exactly, keeping it locked in that chronic state of inflammation.
Wow. So you have this bleeding, inflamed patch of duct tape, and obviously you can't just leave it there.
No, absolutely not.
The sources mention that if topical estrogen doesn't restore the environment, the next step involves chemical cauterization, usually using silver nitrate.
That's right, silver nitrate.
But wait, burning the tissue to heal the tissue sounds incredibly counterintuitive. How does inflicting a chemical burn actually solve an inflammatory problem?
I know it seems like a total paradox. But the silver nitrate applicator is applied directly to the granulation tissue to initiate a process called debriding.
Okay, debriding.
Yeah, the chemical reaction literally burns away the overactive malfunctioning cells on the surface.
Oh, I see.
By chemically destroying that chaotic top layer of tissue, you are forcing the body to hit the reset button. It restarts the healing cascade from scratch, ideally without falling back into that inflammatory loop.
Okay, so we've established that this scar tissue, this duct tape, is biologically totally different from the healthy mucosa. It's stiff, it's oxygen deprived, and it just doesn't stretch.
Right.
Because of this rigidity, the entire pelvic floor is forced to overcompensate, which leads us to like a massive clinical trap that the sources highlight.
A huge trap.
Right, because a patient feels this sensation of looseness or laxity at the vaginal entrance, but the underlying issue is actually stiff, restrictive scar tissue.
Exactly.
If the scar tissue is stiff and restrictive, how does that translate to a feeling of laxity? It feels completely contradictory.
If we connect this to the bigger picture, a loose feeling at the vaginal entrance is frequently not true tissue laxity at all.
Really? Then what is it?
Instead, what you're actually looking at is a tethered or malpositioned perineal scar.
Okay, so the duct tape is pulling things.
Yes, exactly. If that duct tape patch heals tightly on one side, it pulls the surrounding anatomy out of its correct alignment. It alters the whole geometry of the vaginal canal.
Oh, it's like if you're setting up a tent and you pull one stake way too tight, right?
That's a great way to picture it.
The fabric on the opposite side of the tent goes totally slack. So the problem isn't that you have too much fabric or actual looseness. The problem is the tension is completely uneven.
Bingo. And the fallout of that uneven tension is a severe chain reaction.
What happens?
Because the scar lacks elasticity, the surrounding healthy pelvic floor muscles are forced to work overtime just to stabilize the pelvis. Over time, those muscles become completely exhausted from the constant strain, and they go into hypertonus.
Hypertonus, which means they lock into a chronic spasm, right?
Exactly. The levator antemuscles, which are the main sling supporting the pelvis, are essentially stuck in a perpetual tight cramp.
Ouch.
And a muscle that is constantly spasming loses its dynamic ability to contract and relax. It loses its resting tone. So to the patient, that inability to contract feels like weakness or looseness.
Wow. So they read about looseness online, but the clinical reality is actually structural dysfunction.
Completely. This presents as deep underlying pain, cuff tenderness, which is severe inflammation right at the very top of the vaginal vault where the tissue is being constantly pulled, and altered compliance.
And altered compliance basically means the tissue loses its natural springiness, right? It just becomes rigid.
Yes. The tissue can no longer absorb impact or stretch dynamically.
Okay, so if a patient walks into a clinic complaining of feeling loose, and a doctor just accepts that at face value without physically mapping the tension of the scar tissue and checking for hypertonus, they're making a massive misdiagnosis.
A massive misdiagnosis that sets the stage for disaster. You're treating a tension and spasm problem as a simple looseness problem.
Here's where it gets really interesting. Because if the body is already in a state of chronic cramp with this asymmetric tension pulling everything out of alignment, what happens when that patient walks into a clinic asking for a tightening laser?
You get a biological disaster.
Right.
Right.
I mean, we live in an era heavily saturated by the marketing of non-surgical energy devices. Radio frequency or RF devices and CO2 lasers are heavily promoted to tighten vaginal tissue without surgery.
Very heavily marketed.
And the basic mechanism here is thermal energy. They heat the dermis to about, 60 to 75 degrees Celsius to denature the collagen?
That's correct. The heat creates a controlled microinjury. By denaturing or breaking down the existing collagen bonds, the body is triggered to produce new collagen.
So as it heals from the thermal damage, the tissue shrinks and tightens.
That's the idea, yeah.
But wait, if the tissue is already fibrotic and scarred, if they have that tethered scar and hypertonus, doesn't heating it just cook the duct tape?
It absolutely does. It's a very dangerous misconception that scar tissue will respond to energy treatments the same way untreated native tissue does.
So the lasers don't rejuvenate the scar?
Not at all.
Uh-huh.
Referencing the NICE clinical overviews and FDA warnings, applying these thermal devices to unrecognized scar tissue severely compounds the fibrosis.
Oh my God.
You are taking a patch of tissue that is already oxygen deprived and stiff, and you are inflicting a burn injury on it. The body responds by laying down even more fibrous defense tissue.
So you're just piling duct tape on top of duct tape?
Essentially, yes. When you look at the clinical data on women who actually underwent these procedures with underlying scarring, the results are really sobering.
Give me an example. What does the data say?
Well, there's a documented case study of a 68-year-old patient who underwent 3 laser treatments for mild discomfort.
Okay.
Instead of tightening healthy tissue, the laser aggravated a localized area of scarring so severely that she developed a thick, crescent-shaped fibrous band right across her mid-vagina.
Wait, a crescent-shaped band, like a stricture?
Yes, a stricture. The thermal energy triggered an unchecked fibrotic response. That band of scar tissue actually impinged the diameter of the vaginal canal, resulting in a partial obstruction.
That is horrifying.
It gets worse. Her tissues became pale, frail, and entirely inelastic, leading to severe burning, itching, and debilitating pain during intercourse.
All from a treatment that was supposed to just tighten things up.
Exactly. And the data highlights even more complex scenarios. Take the case of a 55-year-old woman with a history of pelvic surgeries, which included mesh placement and removal.
Okay, so she walked into the clinic with a massive amount of underlying deep surgical scarring already there.
Right. And she received 3 laser treatments.
What happened to her?
The result was severe levator antispasms. The thermal trauma pushed her already strained pelvic floor muscles into total hypertonus, creating crippling insertional pain.
So her baseline scarring wasn't resolved at all?
No, it was aggravated to a point of extreme mechanical dysfunction.
So she went in hoping to fix the tension, and the laser essentially welded the tent stakes to the ground. It permanently locked that dysfunction into place.
Welded the tent stakes to the ground. That is exactly what happened, which is why a thorough surgical and physical review is non-negotiable.
Right.
A provider must understand a patient's complete healing history. They have to physically assess the tissue for fibrosis and hypertonus before a laser is ever turned on. You simply cannot treat a mechanical scar problem with a thermal shrinking tool.
Okay, so if we can't just zap a fibrotic scar with a laser, and the feeling of looseness is actually an illusion caused by a tight, tethered scar pulling everything out of whack,
Yeah.
how do you actually fix the tethering and the spasms?
Well, you have to shift the entire clinical paradigm.
It's because you can't just leave a patient navigating a locked, painful pelvic floor.
No, you can't. The medical community has had to move away from the goal of tightening the tissue to actively rehabilitating and reconstructing it.
Okay, so what does that look like?
The clinical guidelines highly recommend a stepwise management approach. First, conservative care via pelvic floor physiotherapy.
But we need to be incredibly specific here about what pelvic floor physiotherapy actually entails in this context. We are not talking about just doing Kegel exercises, right?
Oh, absolutely not. If your pelvic floor is in hypertonus locked in that chronic levator antispasm doing Kegel exercises is like trying to do heavy bicep curls when you already have a severe muscle cramp.
Oh, right. You're just squeezing a muscle that's already stuck in a squeeze.
Exactly. You are asking an exhausted, locked muscle to contract further. You will only aggravate the spasm.
So what is the actual therapy then?
It's much more targeted toward the connective tissue itself. The physiotherapist focuses on manual scar tissue mobilization.
Manual mobilization, like stretching it.
Yes. They use specialized physical techniques to manually stretch and break down the microscopic adhesions within that duct tape.
Oh.
By doing this, they're mechanically increasing the flexibility of the scar and drawing fresh blood flow and therefore oxygen back into that deprived tissue.
That makes total sense. And does that fix the pain too?
Well, that physical manipulation is paired with nervous system desensitization.
Desensitization.
Yeah, because a scarred area that has been pulled tight for months or years becomes hypersensitive. The local nerve endings are constantly firing off pain signals to the brain, which creates a feedback loop that keeps the muscles locked in spasm as a protective defense mechanism.
Ah, so the body is just guarding itself constantly.
Exactly. So the goal is to break that loop. And they do this using biofeedback tools.
How does that work?
The patient uses a sensor that displays their pelvic muscle activity visually on a screen. Because the hypertonus is involuntary at this point, the patient literally has to train their central nervous system to consciously recognize the invisible spasm.
Wow, so they can actually see the spasm on the screen.
Yes. And once they can see it, they can actively downregulate those pain signals to release the pelvic floor. It's essentially reprogramming the brain's relationship with those muscles.
That is incredible, but it sounds like a slow, methodical process of unwinding the damage.
It definitely is. And this raises an important question, though. When is conservative rehabilitation not enough?
Right. What if the scar is just too severe?
Exactly. If the physical therapy reaches its plateau and the duct tape is simply too thick, like with a severe, badly healed episiotomy, that is when surgery is appropriate. Specifically, a procedure called a perineoplasty.
A perineoplasty. And that's fundamentally different from a thermal laser treatment.
Completely different, because it's not trying to shrink what's already there. It is a true reconstructive procedure.
So what do they actually do?
The surgeon physically cuts out the damaged fibrotic scar tissue. They debride the duct tape completely, unpick any old, badly healed underlying structures, and then physically pull the healthy native muscles back together.
So they're literally removing the bad tissue.
Yes, they are restoring the original architecture. By removing the asymmetrical tension of the scar, they allow the pelvic floor muscles to support the organs correctly, finally allowing that chronic spasm to release.
So what does this all mean for you listening right now? It means the goal of pelvic floor recovery shouldn't blindly be tightness, right?
Absolutely not. Tightness is a marketing buzzword. It ignores the fundamental biomechanics of the human body.
Right. The true goal is restored elasticity, comfort, and correct anatomical alignment.
A healthy pelvic floor needs dynamic function. It has to be able to stretch and contract. Scar tissue destroys that dynamic ability, so you must address the scar to restore the function.
Exactly. As we've explored on this deep dive, scar tissue completely changes the rules of the game. You cannot just shrink your way out of pelvic floor dysfunction.
No, you really can't.
Treating it requires a profound respect for the tissue's complex biology. Recognizing that a one-size-fits-all tightening device is not just ineffective, it can be incredibly destructive.
That's the real takeaway here. But, before we wrap up, I want to leave you with a final thought on where this whole field might be heading.
Oh, I'd love to hear that.
We've discussed physical therapy, surgical reconstruction, and the dangers of thermal lasers. But biology itself might hold the ultimate key.
What do you mean?
Well, think about pregnancy. During pregnancy, the human body naturally releases a hormone called relaxin.
Oh, right, relaxin.
Its specific biological function is to progressively reduce tissue stiffness and increase compliance. It literally melts the rigidity of the pelvic ligaments and connective tissue to allow for birth.
Wow, yeah. It just softens everything up.
Exactly. So instead of relying on scalpels to cut out scars or lasers that inflict thermal burns, could the future of pelvic floor recovery lie in harnessing those relaxin pathways?
Wait, really? Like using the hormone itself?
Imagine developing a localized treatment that utilizes the body's own molecular mechanisms to alter collagen turnover, like downregulating production and upregulating the enzymes that degrade it.
To safely melt and remodel fibrotic scar tissue from the inside out.
Exactly.
Imagine replacing the duct tape by just telling the body to rebuild the rubber band. That is fascinating.
It really is the frontier of where things could go.
It perfectly illustrates why we have to keep questioning the simple narratives in medicine and keep seeking the deeper why behind how our bodies heal. So, the next time you see an ad for a quick fix promising to shrink tissue back down like a pair of sweatpants in a hot dryer, remember the duct tape. Treat your body with the complexity it deserves.
Thank you so much for breaking this all down with us today.
Thanks for having me. It was a great discussion.
And to our listeners, until next time, keep diving deep.